Hi, my name is JP Hong from Seoul, Korea, Asan Medical Center. I want to first thank David Chang for the invitation to the Chicago Breast and World Lymphedema Surgery Symposium. Nowadays, the ultrasound has become the main modality for diagnosis in lymphedema surgery in our team. Today, through this talk, I would like to introduce to you what role the ultrasound has for lymphedema surgery, along with the technical aspects of using the lymph ultrasound to map out lymphatics along with the vein, and finally, share some of our experience in using this technique to approach more advanced lymphedema patients. The use of ultrasound is not really new. We've been using it to map out perforators for a very long time, and we've been using it to map out the recipient vessel as well in finding the ideal recipient vessel for the reconstruction, especially in our hands, the lower extremity. Now, if you look at why we have shifted from using the classical CT angiograms to MR angiograms to now using ultrasound, it's because it's just, in one word, much simpler, easier, and it gives you a real-time information. So using the ultrasound, I think we're able to exactly know where the perforators are, and not only that, know the functionality or the physiologic aspect of the perforators, along with the anatomical structures beneath the skin. And this information can be obtained through CT angio or MR angio, or some part of the information could be obtained through the handheld Dopplers. But nevertheless, the ultrasound is the easiest, the real-time, and the simplest way of obtaining these information. So the use of ultrasound has really taken over for us as a major diagnostic modality for the perforator flap reconstruction, especially in the lower extremity. Now, how is that translated or transformed into the lymphedema surgery? Now, if you look at the diagnostic modalities of lymphedema, some of the speakers have already spoken about the lymphintigraphy, the MR lymphangio, and of course the ICG, which is an integral part of mapping the lymphatics. And then there's the lymphangiograms. But for us, we have sort of shifted toward the ultrasound. And the reason why is because if you look at the lymphatic scan or the lymphantigram, what information it gives is just gives you an idea whether or not there's an obstruction of the lymphatic flow. The MR lymphangio also gives a great information, but as you can see here, although it's able to map out deeper lymphatics, we cannot exactly translate to where exactly in our body is that deep lymphatic structure. It's very difficult to map it out in the skin. And of course, ICG is the main modality, but the biggest limitation of the ICG is depth. Once the lymphatic vessels underneath 10 or 15 millimeters, we don't know whether or not there's lymphatic vessels or not. But when you look at this similar graph that I've shown you in regards to the perforator flap, in comparing the MR lymphangio, lymphintigraphy, ICG, and using the ultrasound, you can see that what's really amazing is that the ICG, the penetrating depth, is very shallow, while the ultrasound gives you that whole depth up to 2, 3, even 4 centimeters underneath the skin. It's able to image the lymph node exactly where it is. And most of all, the most important point in using, or the most, I think, the biggest advantage in using ultrasound is that it has the ability to map out veins in adjacent to the lymphatics. So by using the ultrasound, you're able to map out the adjacent vein and also the lymphatic vessels, and actually know where to make the incision in relationship with the vein and the lymphatic vessel. Now, the ICG, because the penetration rate is so low, if it's relatively an early stage, then using the ICG may be more than enough. But in more advanced stages, you have to consider using different modalities to get a deeper picture, like using the ultrasound. And today, I'd like to talk to you a little bit more in depth about using the ultrasound for lymphedema surgery. Now, the goal for LVA is to basically reestablish the physiologic drain from the lymphatic to the vein. So the main components of the LVA are the lymphatic vessels and the vein. Now, if you find the lymphatic vessel and don't find the vein, then we cannot hook it up. So the next question is, if it's the lymphatic vessel and the vein, what is an ideal lymphatic vessel? And for us, the ideal lymphatic vessel is finding functioning lymphatic vessels, as well as large lymphatic vessels. Larger, you just basically have a more easier microanastomosis. Now, the functionality could be seen through the ICG, but you can see that the ICG shows the lymphatic vessels going up. The same thing with the ultrasound. You could actually see the lumen being open, and then you realize, because the lumen is open, then there's functionality. But however, the ICG is really difficult to see whether or not how large the lymphatic vessels are. On the other hand, using the ultrasound, you're able to actually see the diameter of the lymphatic vessel. Now, looking into multiple modalities, of course, you're able to find good lymphatic vessels. But again, in regards to depth and size, I think ultrasound is the best choice in locating lymphatic vessel. So again, for us, it's about locating the functional, the larger, and mostly larger lymphatic vessels are located a little bit deeper, especially deeper to the superficial fascia. So identifying the superficial fascia using the ultrasound and then looking for lymphatic vessels underneath that superficial fascia will be able to allow you to locate the larger lymphatic vessel. And of course, by seeing the patent opening and seeing that open or patent lymphatic structure, you know that lymphatic vessel is functioning. So we talked about how to find the ideal lymphatic vessel. Now, how do you find the ideal vein? So whatever is close to the lymphatic vessel is our main choice. If we're able to see minimal backflow, then we know that the lymphatic pressure is lower and the LV flow would be more dynamic and more better. So we try to find veins that has minimal backflow. So again, using the ultrasound is able to give you that kind of information. So the next question is, what kind of ultrasound can we use? So if you look at ultrasound, some people might see it very confusing, but the basic idea here is higher the frequency, the better the resolution. High frequency will give you crisp, very clear imaging of the lymphatics and the vein. However, higher the frequency, the depth becomes shallow. So higher is shallow, a lower frequency means deeper. So if you're going to be searching for a advanced lymphedema, sometimes needs very, very high frequency because the penetration could be about 1 or 2 centimeters max, then sometimes you'll be not be able to locate the deeper located lymphatics. And if you look at the categories of the ultrasound based on their frequency, low frequency is less than 10 megahertz. And this is the first generation ultrasound diagnostic devices. High frequency is actually termed 10 to 20 megahertz frequency. And this is basically what we see in our daily ultrasound practice. And not only in plastics, but in most of the other fields such as cardiology, anesthesiology, and this is basically the frequency they use. The ultra high frequency is frequency over 20 to 70 megahertz. Now, in order to get ultra high frequency, a lot of the devices don't really have that ultra high frequency. So you have to purchase a very different type of ultrasound. Now, for those usually wanting to start using the ultrasound, you could actually go to your anesthesiologist and borrow these high frequency ultrasounds, and they give you a relatively good resolution, and you could actually control the depth up to 2 to 3,000 centimeters, and this would be enough to basically have an idea to locate the lymphatics and the vein. Now, of course, if you have the luxury to buy the ultra high frequency, then this gives you a crisp image. The imaging is much easier, the learning curve is much easier, basically, and this is really suitable to do to find lymphatics in various depths. So let's take a look at this high frequency ultrasound that most of you will probably have, especially in the OR. The anesthesiologist usually should be using it. And you can see that there are multiple transducers, and the transducers have multiple bandwidth from 10 to 22 megahertz. So for us, we use the first transducer and the last transducer, the hockey stick, which also gives us a imaging around 18 megahertz. And usually this being controlled with the depth usually is enough to find relatively deep lymphatics. So again, using the hockey stick and a relatively high frequency will give you around to around 1.5 to around 3 centimeter depth, and you'll be able to image and, and you'll be able to image the lymphatic vessels. We'll take a look at this video and look at the specifics on how we use the ultrasound to map out lymphatics and the vein. So here is the actual daily practice of using the ultrasound. You can see that we've selected a high frequency probe, a hockey stick probe, and using the GE Logic Q ultrasound, we're actually setting the frequency into 15 megahertz, which would be enough for this patient because we think that the lymphedema is less advanced. Now you could also see that the penetration of the depth, we've set it to around 1.5 centimeters. And now we're setting the color mode area because this will be useful in identifying the vein and the arteries of this region. Now, you could first use the ICG and then trace the lymphatics along. In case where the ICG is not found, then you basically look at the anatomical region with high prevalence of the lymphatic vessel. Now we start using the hockey stick probe to identify the vein first. So you can see that we're finding a luminous structures with lumen, and then we're trying to compress with the hockey stick probe. And when the lumen collapses, we know that this is more of a signal of the vein. So the first is finding the vein. It's much easier to find. And then we're doing the compression test, make sure that it's compressing, identifying that it's the vein. Once we've done that, you could actually start to use the color mode and confirm whether or not that is the vein. You could see that we actually see large veins, and you can see my fellow Dr. Kim pointing it out. You could actually see branches coming out from the large veins. And with the color mode, you could actually see that filling, that signal showing that it is the vein indeed. Now, as we trace along these large veins, you can see that small budding coming out from that large vein, and that is the branch coming out from the superficial vein. And ideally, we want to find these kinds of branches coming out from the large vein because when you hook it up, these small branches, the lymphatic vessels are usually sucked in like a Venturi effect. Now, in order to also identify the vein a little bit easier, you could use a small massage on the proximal part of the leg, which allows a better signal to be identified in the vein. So sometimes massaging the vein increases the vein signal, which just makes it more easier to identify. Now, once we've identified the vein, and you can see that every time it massages, we could actually see that vein being filled with that signal. And then we definitely know that is a venous structure. Once we've identified these venous structure, what we want to do is we want to start searching for the lymphatic vessels that are near to the vein. So now we're starting to look for the lymphatic vessel. You could see that we're first searching as an axial pattern, and you could actually see these small lumens having an axial pattern along the leg. Once you see this, you can see that opaque linear pattern, then we want to go ahead and convert it into the transverse pattern and ultimately try to map out and to diagnose whether or not this lymphatic vessel is functioning. In order to do that, you have to rule out whether or not that is a vein branch. And what we're doing right now is checking under the color mode. And if there's no filling in the color mode, then we suspect that this is a lymphatic vessel. Now we want to transverse the axial, from the axial to the transverse. And now we're actually identifying the lumen, as you can see, right underneath the skin. So we're continuing to probe the lymphatic vessel. And once you see that, what we want to do is we want to compress and release. Unlike the veins, these lymphatic vessel structures are not compressed completely like the vein. So you can see that with the color Doppler signal on, you could actually see that signal being filled in the vein. And in the lymphatics on the left of the screen, you can see that it is not being filled in. So we basically know that that is the lymphatics close to the vein. Again, you can see it with the compression and with the signal. You can see that these lymphatic vessels are not being compressed, and these are not being filled with the signals that you see in the vein. So we basically identify this way the lymphatics and the vein. The next part is that we like to use the ultrasound to actually map out the lymph node as well. Our recent publication actually shows that if you're able to identify functioning lymph nodes, connecting the lymph node to the vein will allow drainage from the lymph node to the vein, and this helps the release of the upper thigh and the pubic region. So again, the same principle, trying to identify the lymph node with the ultrasound, and the lymph node will show a cystic pattern, a nodular cystic pattern. And once we see that, we know that there's a sizable lymph node, and then we will go ahead and find whatever vein structure there is near the lymph node. So here you can see that cystic pattern lymph node right there, like the kidney shape. That is the actual lymph node, and you could actually see the lymphatic vessels going into the lymph node as well. So again, using the ultrasound, making sure that that this is not a vessel, so you're able to identify the lymph node, and also using the color mode, we're also able to identify the surrounding vein as well. Once we've mapped it, we like to map out a linear pattern, that's the vein, and the dotted lines are basically the lymphatic vessel. So in this patient here, which is around early stage 2 patient, in the regards to the mapping, what we want to do is we want to approach the region where it's the closest to the vein and the lymphatics, and we go through, and then we make the incision, trying to identify and see if it's being correlated to the findings that we saw under the ultrasound. So here you can see that the vein is being correlated. We also like to use a different dye. We use a fluorescein dye, which comes up yellow, and you can see the shadows of the yellow lymphatics within that subcutaneous fat. Once you've identified the vein, we go ahead and start to identify the lymphatics, and you can see that it correlates very well with the dotted line, also with the linear line shown to be the vein structure. So we're going to go ahead and dissect a little bit more near the dotted zone to identify the lymphatic vessel. And once we identify the lymphatic vessel, we'll go ahead and confirm this with the ICG intraoperatively. You can see the branch coming out from the vein as the ultrasound showed. So we'll use that vein that comes out from the larger vein to hook it up to the lymphatic vessels, which is going underneath the vein. And you can see that exactly like the mapping that we draw on the skin, this is the overlapping area. So that way we don't have to have a long dissection between the vein and the lymphatics. As you've just seen the video, we'd like to finally hook up to the side of the lymphatics using the end of the vein. That way we believe that it will be collected from proximal as well as distal. Our main modality now has been the side of the lymphatics using the end of the vein. Now let's quickly take a look at some more advanced cases. Now this video will probably give you a better idea on how we use the ultrasound, especially in more advanced cases. So let's take a look at patient 1 here. This patient is a relatively early stage lymphedema, too early, and you can see that by using the ICG, there's clearly a functioning lymphatic vessels. So we confirmed that with the ultrasound, and we try to find the nearest vein, the vein nearest to the lymphatic vessel. And as you can see here, it's clearly mapped using the ultrasound. Let's take a look at patient 2 with a more advanced lymphedema. You can see that this patient has a stardust pattern, and of course, there's no linear lymphatics. In some of the cases, we will discuss a little bit later, but in the severe advanced cases, even using the ultrasound sometimes does not reveal any functioning lymphatics. So in these kind of cases, we then resort to other measures such as the lymph node transfers instead of wasting time doing the LVA. So here you could see that only the vein is identifiable without being able to identify any lymphatics. Same thing, more advanced patient with stage 3. This patient here is seen with only a stardust pattern in the ICG. The vein is easily identified, but now look at the lymphatics. So even though there's a stardust pattern, you're still able to identify lymphatics in these more advanced cases. So by using the ultrasound, now we know that even for advanced cases where the ICG is not apparently showing functioning lymphatic vessels, using the ultrasound allows you to map out the functioning lymphatic vessel and ultimately find the adjacent vein and do the LVA as shown in this video. So what about using a more ultra-high frequency ultrasound, such as 20 to 70 megahertz? Again, even though the depth could be a little shallow, it just gives you an incredible image. This is a ultra-high frequency ultrasound, and this picture was actually donated by Dr. Aki Hayashi, my good friend from Japan, and you could actually see a linear pattern, beautifully showing the lumen, and which is an evidence for functioning. At the same time, you're able to see the adjacent vein, which makes it very, very easy to actually map out the functioning lymphatic vessel. The higher the frequency goes, you could see that you're even able to look at the lymphatic valves, as you can see here in this ultra high frequency mode. So using this kind of ultra high frequency ultrasound will give you a much more enhanced imaging if you have the luxury to buy it. But nevertheless, using high frequency, although the learning curve may be a little bit high, you can see that it's a little bit tricky and you need to use a compression test to exactly identify whether or not that is a lymphatic vessel or a vein. So there is a learning curve. If you have an ultra high frequency, that learning curve is far less and much more easy to identify, but nevertheless, the penetration depth could be a little bit shallow than the more just regular high frequency ultrasound. I think this is a very user-dependent modality. Some, residents or fellows or faculty member does it really, really well, and some just can't. And of course, definitely there are some cost benefits. Instead of getting an MR lymphangiogram, just doing a ultrasound really has its advantage in cost. So the high and the ultra high frequency ultrasound really allows you to identify functioning lymphatics. For me, it also allows to identify larger lymphatics when multiple lymphatics are there. It also allows me to select the ideal vein with minimal backflow, as well as locating the closest vein near the lymphatic vessel. And it just gives you a much more accurate preoperative planning and overall decreases your surgical time, increasing the efficiency overall. So again, going back to this overall description of the multiple imaging modalities, I do believe that the ultrasound is the best value for your money. Of course, ICG is simpler and easier, but if not, if a little bit more advanced cases, along with identifying the vein, I think the ultrasound is just much, much more better. So basically, the practical approach is for the early stage, I think ICG is more than enough. However, you might have some trouble finding the adjacent vein. But for more advanced stages, again, when ICG is not able to penetrate the depth and find that deeper lymphatic vessel, I think the ultrasound definitely has its value in addition to map the veins. Now, this becomes more valuable, especially in advanced status of lymphedema. However, we saw that despite being able to map with the ultrasound, 7 to 8% were not able to do lymphatics because with using the high frequency ultrasound, we were not able to exactly see whether or not how severe the fibrosis or the sclerosis of the lymphatic wall was. However, by using the ultrasound, the high frequency ultrasound, you'll be able to get that 7 to 8% imaging and actually say, hey, look, this is not a doable lymphatic vessel. So again, this is the benefits of using the ultra high frequency ultrasound. By using the ultrasound, around 6 to 7% had no identifiable lymphatic vessels in stage 3. So it really allows you to sort of plan the approach from the beginning instead of wasting your time trying to map out or find the lymphatic vessel. So I think by using this approach, we've also shown that in late stage 2 and stage 3 advanced lymphedema patients, it was a very effective approach in reducing the overall circumference. I think by using this approach with a junction with ICG, now we are able to solidify the concept of functional lymphatic vessels, leading to a functional LVA. And we're also able to now change the approach for stage 3 lymphedema as well, finding these functional lymphatics deep in subcutaneous fat and able to provide a LV bypass and allowing a solution for these advanced lymphedema patients. So I think that is my talk for you today by using ultrasound, and I'll be more than happy to answer any questions. Again, thank you, David Chang, for the invitation, and thank you, Jami Masia and Minghui, for the invitation as well to the World Lymphedema Surgery Symposium. So with that, thank you, and I'll be happy to answer.